And now we call for this next session, session 17, meet the international guest speaker. We call for the chairpersons, Professor Muhammad Awad Tajuddin, Professor Ashraf Al-Maraghi, Professor Haitham Sami, and me. There used to be 2 lectures in this partition, but we will introduce one, and the other one will be after the GSK symposium. My first presentation, I would like to welcome Professor Magdi Idris. He's today going to give us his presentation. This presentation, Dr. Magdi gave it about 1 month ago in a conference, and I was really impressed by this presentation. It's something that every physician and every doctor needs to know before going in any presentation, even in a local or an international conference. I think me, for the start, I'm going to learn a lot from this presentation, and I think all the audience will enjoy this such a wonderful, highly informative presentation. Good morning, Dr. Magdi. Dr. Magdi, can you hear me?
Yes, I can hear you very well. Good morning to you all. Thank you so much for the invitation. It's a great honor to be among this international level meeting, and definitely it's an honor to be in any meeting where Professor Muhammad Awad Tajuddin is chairing, and yourself, Dr. Really, Iman. It's really an honor, and thank you so much. Unfortunately, I couldn't be with you this time because other commitment. Like, inshallah, next time we'll be together really in person. Thank you again.
And on behalf of the board and on behalf of the society, we'd like to thank you for giving us from your time and from your effort to give this presentation in the weekend. Thank you, Professor Magdi.
Thank you.
Good morning, Magdi.
اهلا وسهلا ازيك صباح النور والسرور يا رب.
Always we appreciate your contribution in our meetings.
It's an honor, sir. It's an honor.
A very prominent figure in the field of thoracic medicine, and your lectures
always from you
is very nice and expose every new in our field of medicine. And we are looking always to see you here in Cairo, so that next time in the near future we will looking to see you.
Inshallah.
Magdi is a very old friend, older not by age, older by the deep friendship. Thank you, Magdi.
Indeed, thank you. So if I can, I'm going to share my slides, and please let me know if you can see my slides very well. Can you see my slides? Okay.
Now you can start your presentation.
Okay. Thank you so much. So I was asked by Dr. Iman to give a talk about how to be a good speaker, which I think personally, it's extremely important when it comes to our professionalism when we give a talk. And there is very nice say by Sir George Jessel when he said the human brain is a wonderful thing. It starts to work the moment we are born and never stop until we stand up to speak in public. So really we know that speaking in public is not an easy thing. And many people struggle. They might be good scientists, great scientists, but when they talk in public, they might have challenges. They feel very anxious. So there is a technique to learn about really talking in public. And I'm going to refer you to this wonderful book written probably more than a decade ago by Stephen R. Covey. Basically, the last Stephen Covey, he died a few years ago, but he wrote a wonderful book about the 7 habits of highly effective people. And I hope that everyone read this book because it could be a life changer. But if not, please go ahead and read it tonight. It's a fascinating book. And I'm going to quote that book to try to tell you the 7 habits of highly effective communicator. Because to me, we need to learn habits about how to communicate and how to speak. And it's very well known that good communicator is saying something in a way which can be understood, but always great communicator who is that person who cannot be misunderstood. Because sometimes you might feel that you did understand what the other person told you, And that's good communication, but really great communication when there is no chance for misunderstanding. So would like always to be at the level of really great communicator. So what are the 7 habits for highly effective communicator or speaker? That's extremely important when we try to understand basically the concept of giving a talk. And the 7 habits that I'm going to go quickly over is master the trio of presenting, go from the B of the bang, practice mails, use visual aid, but don't abuse them, hire an agent, and then timing, and finally is practice. Let's go quickly over these 7 habits. So master the trio of presentation. What do you mean by that? And I mean by that, by really any presentation, it has 3 parts. It has definitely the content of the talk, which is the message that you are giving, but there is 2 other important parts that are, or sometimes missed by the speaker, are the voice and the body language. It's very important that when you give a talk, your body language should be ideal. So basically the gesture, eye contact, you should always have eye contact with different basically audience. Don't concentrate on your slides, don't concentrate on one person, don't concentrate on the chairperson. Always have eye contact with the speakers all over the room. So that will help the people to get engaged with you. Always smile, not too much smiling, but keep a smile on your face and have a good gesture. Now, the voice is very important. You should not be basically monotonic. So you should not talk like this. I believe that bronchial asthma is a very important disease because it affects. This is not good. People will get quickly basically disengaged with you. Your volume should go up and down. The variety of your really pitch and tone should move according to your message. So sometimes you can say, what I would like to tell you in a little bit louder tone than when we say the conclusion is. So you go down with your tone to give another message. So that's extremely important. And I'm not going to talk about the context, although it is always the most important. But unfortunately, what people told us from the statistic that after a good talk, the people will get only 7% of your message. The most of what's gonna get after your talk, the impression is about your body language and about the sound, your voice. So don't ever believe that your talk will make it changes in the whole situation and it will teach everything about that topics. That's not gonna happen. When you give a talk, you are giving messages. And then people should take that message to go and read about the topic. Now, the second habit is go from the B of the bag. And what do we mean by that? We mean that start strong. It's very important to start strong, to get people engaged. So if you miss that chance, you're going to see people on their cell phone, not looking at you, talking with each other. That's a problem. So always there's a good tactic to start with a story about the topic, anecdote, statistic. You can start by asking them question, so they get really engaged. So, for example, if I'm talking about asthma, I will start saying, "What do you think about the level of asthma control in Egypt?" So really, I started by question to engage people with me. That's extremely important. Now, your tactic could be different. Most people start with really introduction, background, the current knowledge, and conclusion. However, some good speakers start with the conclusion and end with the conclusion. It just to double the dose of the conclusion. For example, if you asked me to talk about biologics in asthma, I will start by saying that biologic in asthma have made great revolution in the management of asthma. So I started with a conclusion, and then I showed them the data, and then came back at the end. I will say, in conclusion, I showed you data that biologics in asthma has made a major revolution. So I started with a conclusion and ended with a conclusion. And that's a good tactic that some good speakers do sometimes. Practice males. And excuse me, there is nothing here really against female at all, but I'm just talking about the MALES. the messages, the audience, the language, example, and summary. You should have tactic in each one of those basically title in order to deliver a very good talk. So when we go talk about basically the message, it's very important. The volume of information is not as similar to the value of information. I'm not expecting you to give me a textbook lecture about ILD or asthma or pulmonary hypertension. You don't need to show me that you did a lot of reading and you get all the studies and then the different textbook. That's not the point of your talk. The point of your talk is just to give specific messages. And this is very nice equation that everybody look at. 9 times 1 equal to 0. 2 times 3 equals to 1. What do we mean by that? We mean by that if you have 9 messages in your talk and you repeat each message once, the audience at the end of your talk will get 0. They're going to get overwhelmed with the amount of information. But if you have 2 messages in your talk, and then you repeat those messages 3 times during your talk, then the people will go out probably with 1 message. So it's important to understand that the value of your information is not similar to the volume of your information. Now, and always you need to really understand that the fewer and the clearer the messages is really, I'll say better. That's what you should really do. And when you talk about your message, inform them, entertain them, put some education, and then support that by the good clinical practice, because that's extremely important. What about audience? You need to know very well your audience. So, because if you talk to a specialist, for example, I'm giving a talk about pulmonary hypertension and I'm talking to PH doctor, those will be in the red, basically vertical line. And I'm going to focus about one specific things about the pathobiology of pulmonary hypertension. However, if I'm talking about, for example, GPs, which is the horizontal blue lines, then I'm not going to talk about the really pathobiology and the basic science of pH. I'm going to probably talk about epidemiology and how to make a diagnosis. Most of your time, your target audience is mixed. So you need to really prepare your talk to be not too highly specified at expert level, but really not at the level of medical students. So you need to choose your talk to match your audience. Language and grammar. This is the most important things to me. There should be no spelling mistakes in your presentation. Please, please, please. I'm talking those to the junior doctor when they give a talk. You are now the elite of the elite in the society. It's not acceptable to have spelling mistakes in your presentation. And also the grammar should be well maintained. So watch the uppercase and the lowercase. For example, don't use a capital letter in some sentence and small letters in really at the beginning of other sentences. And learn the technique of the period, comma, and bracket. What's the normal really way or the right way of writing is when you have a full stop, you should leave 1 space between the full stop and the next letter. Don't do this. Don't put full stop and follow immediately with the letter. On the contrary, after the word, the comma or the full stop come immediately. You should not leave a space. Very similarly, when you have a brackets, don't leave a space in between. And I'm going to show you some example from our own doctors, our own basically fellows, that they basically presenting this case. So this is a single non-smoker or alcoholic, a student with good performance, admitted with severe, basically asthma. So if you look at that, there's a lot of issues to me. And I always ask the resident or the fellow, I say, be careful about your spelling, because the right way is to do this. There should be no space after single. There should be, with a good performance, no space with the brackets. And then there should be no small letter, capital letter, should be capital letter. Severe asthma, always written with E. this is basically sever, and sever means really shredding. Basically Rajul al-Akhdar, when he used to really sever his clothes. So that's sever. So always be careful with your spelling. When you give a talk, especially in international meeting, it will be a problem. Another example, so one of my fellow wrote this, and when I look at it, I said, please be careful. There is two spelling mistakes. There is a lot of problem in the capital letters, small letters, again, leaving spaces, etc. So this technique is a must, and it really reflects your level as a speaker. Yes, your message, your talk is important, but your slides should be as good as well. Now, and as I said, always give example when you give a talk. Always say that I saw a patient last week talking about the same things. You can talk about story that happened to you. Give some joke, but not too many jokes, because that will turn your talk into basically professional talk. The fourth habit is use visual aid, but don't abuse that. And what I mean by that is be careful with your slides. So the classical way of making slides, we're saying that maximum is 6 lines per slide, 6 word really per line. The lesser, the better. You can even do less than that. Basically, put phrases and word, but don't make sentence and then you start reading your slides, because you can simply put your slide and people can read it. So this habits of putting a lot of really basically wording and sentences and you start reading that slide is not good things. Basically, avoid the small font, avoid busy slide, and be professional. What do I mean by that? So small fonts is really a problem because the audience cannot read your slides. So always use at least basically 24, 28, etc. Don't use busy slide like this. This is not good. Nobody can read it except you. And when you put that kind of slide and then you start reading it, people will immediately will be disconnected from you. When you put busy slides, sometimes we have to put busy slide, for example, table. So once you do that, have the habit to highlight what you want to tell them, and really always basically walk with your audience with your say. So if you have this busy slide, I will say the important point in this slide, this is busy slide, but it is this and this and that. So now the people can focus and not get overwhelmed. And definitely be professional. I mean, especially if you are talking in a medical conference or something. I mean, it differs where are you, but for example, don't use these things, basically animations, those things, flies that really rotate. Don't use things like very pinky colored slides, multiple basically really color and different wording. That's really not good. Maybe if you're giving a talk in the birthday of your 5 years old daughter, yes, you can use that, but not definitely in a medical conference. And it's always important to learn the technique of talking. So pausing is very, very strong message. So when you say something important or when you ask a question, pause. For example, you say, you know how good is biologics in asthma? And then I stop for 2-3 seconds to let people start thinking with me about what I'm going to say next. So, and let audience hear and feel with you what you are doing basically next. Give only one main message per slides. Don't mix a lot of information. Watch your body language. And beware of the laser pointer. Many speakers, they just use the laser pointer and they can sometimes basically really even fire the eyes of the chairperson of some speakers. So please don't do that. If you want to use the laser pointer, be focused on what you want to show them. Hire an agent. What I mean by that is use the audience to be part of your talk. And the best time to do that is during question and answer session. So it is your opportunity to actively engage with your audience. So when they ask you a question, the one who is asking you the question, please always look towards him look him in the eye while he is asking you the question. Now, after he finished or she finished the question, turn to the audience and engage them with you. That's extremely important. So really, when somebody is asking me, I'm looking at him, but when I am answering, I don't answer him, I answer the group. So I really look at the group. You can re-emphasize your point, introduce new and positive information. Sometimes you don't need to really tell everything during your talk. You can keep something to the really information. And always don't allow the audience to take you away from your message. For example, if I'm talking about the role of inhaled steroid in bronchial asthma, and then somebody asks me about COPD. Now, I don't want to answer COPD question. I want people to keep focusing on ICS in asthma. So what I will do, I will say things like this. Yes, COPD is important disease, but then I'm going to bridge them back. I'm going to take them back to the asthma. But the main message is about controlling inflammation, and asthma is the disease of inflammation where inhaled steroid. Basically at the beginning, I acknowledge that I understood the question, but my answer was towards what I want to do. And you can use different tactic, different messages, basically what they call as really bridging messages, really in this case. And definitely politicians do great job on this. My last two slides, timing. Please don't ever go beyond your allotted time. That's extremely important. It is kind of disrespectful to the meeting. It is disrespectful to your next speaker, basically colleague. It's not good. Stick to your timing and don't ever go. And of course, practice before you give the talk. And I'm trying here to really mention that remember the 7 habits of highly effective people. And remember that good presenter has ideas, bad presenters has only slides. And thank you so much for your kind attention. Really appreciate it.
Thank you so much, Professor Magdi Idris, for your very comprehensive and intelligent talk. And we are looking forward to have you in Cairo soon. I would like to present this next session, my mentor.
Professor Magdi, thank you very much for your contribution. And we know very well that you are pioneer and one of the best expertise in the world in the field of pulmonary hypertension. But now you confirm, we know that, but you confirm that you are a very good teacher and you give us a very good points about the good teacher and at the same time, how to give a good lecture.
Thank you so much, sir.
A very important point, it must be delivered now to my colleagues. You must match your time. Thank you very much.
Thank you so much, sir. Thank you. See you all. Bye.
Thank you, Magdi.
بسم الله الرحمن الرحيم. احنا بس هنقدم recorded lecture for international speaker. كانت متأجلة بس قبل البريك لظروف الصلاة. احنا هنقدم lecture بعنوان newer advances in lung nodule diagnosis, augmented fluoroscopy, cone beam CT and Archimedes. هيقدمها لنا بروفيسور فينتاكا ماتورو.
Good morning, everyone. Greetings from Hyderabad, India. So in the next 20 minutes, I will be talking about the newer advances in lung nodule diagnostics. So it's indeed a privilege for me to be a part of this 65th Annual International Congress of the Egyptian Society of Chest Diseases. And special thanks to my dear friend, Dr. Haitham. So because of whom I will be delivering the lecture today. So a couple of pictures from the memories. The first one was 2 years back when I was in Cairo for one of the conferences. And the second one was last year when we had the privilege to have Dr. Haitham as the faculty for one of our international events. So with this brief introduction, Though I'm sad that I'm not there in person today, I will be talking about three new things which will likely change the way we practice peripheral bronchoscopy and diagnosing peripheral lung nodules. So that is the augmented fluoroscopy, the cone beam CT, and airway tunneling. These are the three things I will be talking about. So starting off with the basics as to why we need this technology. So whenever we have a lung nodule, you either can do a CT guided biopsy or a bronchoscopic biopsy. So as we all know, the diagnostic yield of CT guided biopsy is to the tune of 90%, whereas bronchoscopic biopsy is not as close to 90%, it is slightly lesser. So the problem with CT guided biopsy is the higher rate of complications, that is pneumothorax and bleeding. Now, why does CT-guided biopsy have a higher diagnostic yield as compared to bronchoscopy? This is something which we have to understand. So, one is called as a tool-in lesion. So, whenever a radiologist does CT-guided biopsy, if you can see the pictures on the right, they can actually see the biopsy needle directly in the nodule, do a CT, confirm, and then take a biopsy. So, their confidence and the diagnostic yield will be much higher. Second reason why CT-guided biopsy has a higher diagnostic yield is because they do not follow the airways. They will puncture the lung and go wherever they want to go. So they can reach more nodules as compared to what we can reach through bronchoscopy. Now, bronchoscopy also has been evolving over the decades. Before 2002, there was no radial EBUS. The diagnostic yield was very less because we were not able to see the nodule. Once radial EBUS came, you were able to see the nodule through ultrasound, the diagnostic yield went up to 60 or sometimes 70%, but still 70% is less than 90%. So several new technologies have been added, and these I will be talking about because of which the nodule diagnostics have gone up to 85 or 90%. So what are these technologies? As I have said, there are two reasons why CT-guided biopsy is better is one, ability to reach the nodule better, or ability to see the tool in lesion. So how can we see the tool in lesion through a bronchoscopic biopsy? One is through a fluoroscopy. So Redilibus does not give real-time tool in lesion. That is the main disadvantage. But if you add fluoroscopy to Redilibus, then you can see the biopsy forceps while we are sampling. Second important technique is the cone beam CT, which will give the three-dimensional tool in lesion, which I'll be talking about. Then how to reach the nodule? You have navigation technologies. Happy that both India and Egypt both have the lung point by bronchus. You also have Fuji Synapse equipment, which is there in India. You have thinner scopes now and the ultra thin scopes also. And more recently, we also have the tunneling techniques where you puncture the airway, go out of the airway. This again, I'll be talking briefly. So quickly starting to what is augmented fluoroscopy. Something like seeing the unseen. So on a fluoroscopy, which is a picture on the left, if there is a large lesion, you can see on a fluoroscopy. But if it's a small lesion, or if it's a lesion which is retrodiaphragmatic or retrocardiac, you won't be able to see it on a fluoroscopy. So what do we do in augmented fluoroscopy is we augment the normal fluoroscopy with the outline of the image, outline of the nodule. So this is the right one is the augmented fluoro. So a lesion which is otherwise not seen on fluoro will be seen on augmented fluoro. This will help us in guiding the forceps or the cryoscope to the target. So that is augmented fluoro. Some more pictures here. You can see here on the top, you have the nodule which is retrodiaphragmatic and the bronchoscope going in there. Another nodule which is very small subcentimetric nodule, otherwise not seen on fluoro, can be seen on augmented fluoro. So this is another image of a nodule in the right mid zone, which is not seen on fluoro but can be seen on augmented fluoro. So which are the technologies where augmented fluoro is available? Cone beam CT has augmented fluoro. Archimedes is augmented fluoro. The lung vision by body vision is augmented fluoro. So these are all the newer technologies which have augmented fluoro. You can mark the lesion and the path, both of them will be projected on the conventional fluoroscopy. So one more case where you can see a small lesion in the hilum, where you mark it, you can see the path, and then you can see the bronchoscope and the cryoprobe going directly into the target. So that is what is known as augmented fluoroscopy. Now we'll come to cone beam CT. I will spend a little bit more time at the cone beam CT because this is something which is revolutionizing the way we sample peripheral lung nodules. So I'll give a brief introduction, how we do it, steps and advantages and our initial experience. So this is a typical example of a cone beam CT. You have a console room and you have the cone beam CT lab, CBCT lab. So most cardiology cath labs have a cone beam CT. If you can install the lung software, you can use the cone beam CT. So what exactly is cone beam CT? It is nothing but an intra-procedural CT scan. Just like surgeons do intra-procedural MR, you do an intra-procedural CT. Once the patient is induced, you do a CT so that you will mark the lesion correctly. You can see the Turin lesion. It helps us overcome the CT to body divergence, which is one of the main reasons for lower diagnosis in cases of peripheral bronchoscopic sampling. So how is EPCT done? Basically, you have a cone-shaped beam. That is what's called as a cone beam. And there is a flat detector and there is a gantry which rotates 180 degrees. So a series of X-rays are captured and that is converted to a CT scan. So as compared to a cone beam CT versus a normal CT, the cone beam CT is a quicker scan, but it has a lesser radiation dose, lesser resolution, and it is less expensive. So it is definitely not as clear as a normal CT, but it gives us a good CT picture and a three-dimensional orientation. The various types of cone beam CTs, you have floor mounted, roof mounted, biplanar, and the mobile cone beam CTs. Whatever technology you choose, it is important that the gantry is on the left side, not at the head end. When the cardiology does the procedure, the gantry or the rotation happens from the head end of the table. But for bronchoscopy, the table will be like this and the gantry should be like this from this side. Huh? So, of the 5 steps of sampling peripheral lung nodule, cone beam CT will help in navigating target and to see the target and the Turin lesion. That is the most important thing. This is a recent meta-analysis of 800 plus patients where it has been shown that if you add cone beam CT to navigation and radial bus, your yield can go up to 85% with a very, very low complication rate of 1 to 2%. So how do we do cone beam CT? Basically, this is the scan. This is the lab which we have, the Philips Cellura. This is the exact system which we use. This is the car cone beam CT room. So you have the CBCT gantry on the left side of the patient. The bronchoscopy will stand at the head end of the patient. The anesthesia also will be on the left side. The bronchoscopy X-ray is on the right side and the console room outside. So there are 6 steps. First is to induce the patient. All the procedures are done under a general anesthesia with what we call as a lung navigation ventilation protocol. So basically use a high PEEP of 10 to 14. This is basically to prevent atelectasis. And to make sure that the airways are open. Then we do what we call as isocentering. I'll be showing about all of these in a small video. You do AP and lateral isocentering. You do the first CBCT spin so that you will capture the three-dimensional location of the nodule. Then you mark the nodule on the console. You come back to the bronchoscopy. You do the bronchoscopy. Once you mark the lesion on the console, your augmented fluoro will be active. So you guide the target, the tool, to the nodule. Then you fix the bronchoscope. And again, you do the CBCT spin. You can see the bronchoscope is fixed. You do the second CBCT spin. Then you can confirm that the probe is in the center of the nodule. And then you do the biopsy. So these 7 steps I will try to show briefly in a small video, which goes for around 6 minutes or so. So this after induction, so you do what we call as isocentering. So basically we are trying to make sure that the fluoroscopy captures the target. So you do isocentering in the AB plane and the lateral plane. You can see this is the lateral isocentering. You make sure that the entire target laterally and AP is in the center of the fluoroscopic loop. Then this is called as the collision spin. So basically we make sure that when the CT scan is being done, there is nothing which is obstructing the way of the gantry. That's called as the gantry. That's called as collision spin. Once you do the collision spin, the anesthetist will keep the ventilator on an inspiratory hold. So at a PEEP of 14, he'll put an inspiratory hold and he'll go out of the room. And then the first cone beam CT spin is done. This is the initial cone beam CT spin, which is being done. It takes around 8 seconds. The newer scans will take only 6 seconds. So our center has a technology which will have a 8-second spin. Then the bronchoscopist will go to the console and then mark the CT, mark the nodule on the CT scan. So you can adjust the slice thickness, you can adjust the brightness, you can use the lung window, and then you zoom, you mark the target which you want to biopsy, whichever you want. So this is called as the intra-procedural CT scan. So once you induce the patient, you do the scan. So this will help overcome the CT to body divergence. Here you have a target which is in the paracardiac location. So we know where the target is. So you mark the target. This is on the axial, lateral, and the sagittal plane. So this is what is being done. You're trying to mark the target. So on all the 3 planes, you make sure that you're actually basically a 3-dimensional marking of the target. So you're trying to adjust it on the other planes also, the sagittal and the coronal planes. Once you do the marking, then you can also mark the path which goes to the target, or you need not mark the path, you can directly navigate. So we'll try to see if we can mark the path, but in this case, I think we have not marked the path. And then once you do that, you start the procedure. So this is the initial planning. So you do the isocentering, you capture the initial CBCT, then you mark the lesion on the CT scan. This is all pre-bronchoscopy preparation which is done. So once you do the pre-bronchoscopy preparation, you again go back and start the procedure. So this is when the procedure starts. So there you can see now the thin bronchoscope is passed inside when we're trying to pass the radial EVAs and now locate the target. So how do we locate the target? Again, if you can so once the radial EBUS is inside, now you activate the augmented fluoroscopy. So the radial EBUS, you can say, going into one of the segments. So if once you get a image which is likely to be the nodule, you also reconfirm it on an augmented fluoroscopy. So that is what is advantage of a cone beam. So you can see here, this is the target. Now what we can see is with the best of the things, you're able to go to the periphery of the target. That is called as a tool touch lesion. Not in the center, but in the periphery. Even that is okay. Once you do the best navigation, you fix the bronchoscope using a bronchoscope stabilizing system. This is the Mediflex bronchoscope stabilizing system. So now you want to recheck whether you are exactly in the target or not. So now your Radialibus probe or with cryoprobe, we have passed it such that you are in the target. So you fix the bronchoscope with the cryoprobe there. You fix the cryoprobe, make sure that it doesn't move, and then you do the second CBCT spin. So this is the fixing of the tool and the fixing of the bronchoscope inside. Again, we give an inspiratory hold, you go out of the console, do the second CBCT spin. This is the second CBCT spin. Now you can see the bronchoscope is inside and the tool is also inside the target. So again, you go back to the console and now you make sure that your target, your tools, you can see the cryoprobe there, which is touching the target. So we are close to where we want to sample. You can see here, you can see carefully that on the axial plane, the target and the tool are exactly very close by. So you're very, very sure that you have reached your target. So here we have got what we call as a tool touch lesion. Many times we got a tool in lesion also. So once you confirm that you've reached it, it's called as a three-dimensional tool in lesion. So once you confirm, then you go back to the bronchoscopy, CBCT room, and then you do the biopsy. So you can do either a forceps biopsy or a cryobiopsy. So you can see here the cryoprobe is actually touching the target, and then we are sure that we will probably get a diagnosis. So now the last step is performing the biopsy. So for the sake of time, I will not show how a biopsy is being done. Now, as I have said, the advantages of CBCT are one, augmented fluoro, which I have shown. The second is known as multidimensional fluoroscopy. This is again very important that it is, on a fluoroscope is a two-dimensional image. So if the target is here, if your tool is here, here, or here, if you do a one plane, you will probably see that it is correct. So in a CBCT, or what we do is we do 3 dimensions. One is 0 degrees. You can see the country is 0 degrees and you are in the center of the target. Second, this is called as RAO, right anterior oblique. You move 30 degrees like this and then take an image. Again, the tool is in the target. Then you do LAO, minus 30 plus 30 degrees. Again, you can see the target and the tool is in the target. So on 3 planes, if you confirm that the tool is in the target, then you are very sure that you are in the center of the target. The other advantage of CBCT I have said is 3-dimensional tool in lesion. In fact, this is the only technology which gives a 3-dimensional tool in lesion. You can see this is one of the cases where we got a center strike. The small lesion and the crab probe is in the center on coronal, sagittal and axial planes. And then you can actually do the biopsy. So it's called a 3-dimensional tool in lesion. This is the biggest advantage. And based on this, you can have 3 patterns. This type 1, where the target tool is in the center, type 2, where we have a tool touch lesion, and type 3, where we are away from the target. Our initial experience of now we have done around 50 plus cases in the last 1 year. So most of them are middle-aged, 55 to 60 years. The mean diameter was around, I would say, 15 to 20 mm. Most of them were below 2 centimeter nodules. Most of them in the lower lobes, upper lobes, around 50% in the upper lobes, and most of them in the periphery of the lungs. Very few had a bronchus sign. Most cases we use a lung point virtual bronchoscopic navigation. 50% had a path, 50% didn't have a path. We always use a thin scope or an ultra thin scope. In radial EBUS, 90% of the times we get an image. 35% concentric, 65% eccentric. Average time to reach the lesion 7 minutes. The number of spins on average is 2, sometimes 3. If you can see, most cases we use augmented fluoroscopy, sometimes multidimensional fluoroscopy also. So tool in lesion 37%, tool touch lesion 63%, and complications are very less. Atelectasis is lesser, and the diagnostic yield is around 84% in our center, which is very similar to the international standards where we have 80%. So despite the fact that our nodules have lesser bronchus sign, the diagnostic yield is to the tune of 85%. What are the factors affecting the diagnostic yield? To some extent, the size. The larger the size, the better the diagnostic yield. If we have a tool in lesion, we have a higher diagnostic yield. And as the experience increases, the first 12 cases, 75, then 83, then 92%. So last couple of cases, we have 90% diagnostic yield. So the last part of my talk is the airway tunneling technologies. So when we do not have an airway path, CBCT also will go through the airways. You can tunnel, puncture, go and take a biopsy. This is where Archimedes will help. So in Archimedes, you use a therapeutic bronchoscope. The software gives us an avascular path. There is a point of entry. You put a needle, flex needle, you puncture, you dilate, you put a sheath across, you go inside and then do the sampling. Again, Archimedes has fluoroscope. So this is one of our cases where we had performed Archimedes. If you can see, there is a nodule, peripheral lung nodule in the right upper lobe posterior segment. A CT-guided biopsy was done, which was inconclusive. The normal navigation could not give an airway path to the nodule. So we decided to do Archimedes or tunneling in this particular case. So this is the software which gives us an avascular path and the point of entry. It gave us a point of entry in the right upper lobe posterior segment. That was where the flex needle is now being directed. This is the flex needle. So they have a point of entry, and then you puncture the airway at the point of entry. So you can see the puncture has been done. So once you puncture, you remove the needle and you put the sheath. So the Archimedes sheath will come inside. You will be seeing the sheath shortly. So the sheath also has a balloon. So you can dilate the entry point and then pass the sheath out of the airway. You can see here. So in this particular case, the balloon was not required. So the sheath directly went out. So you can see the sheath went outside the airway. Once you go out of the airway, you cannot do a bronchoscopic path. You go the fluoroscopic way. You have the augmented fluoro again in Archimedes. You see the sheath is advanced to the target and you confirm in 3 planes. See the AP minus 30 and plus 30 again. And then again you pass the forceps. You can see the biopsy forceps there and the cryoprobe. Again under direct visualization through augmented fluoro, you take a biopsy. And then post procedure also you can see there's not much of bleeding which happened. Usually no pneumothorax also happens. And then you will get an accurate diagnosis. So this is how a BTPNA is performed. That tunneling technique is performed. Because of lack of time, I'll not be showing other cases. There's other techniques called as mini BTPNA. So to summarize my talk, the augmented fluoroscopy is a very useful technology which will help us see smaller nodules which are otherwise not seen on fluoroscopy on the C-arm. CBCT is obviously the new thing, and this is how we all have to go. It is the only technology which gives us a 3-dimensional tool in lesion. It will help us overcome the CT to body divergence, and the diagnostic yield goes up to 85 or 90%. And the last thing is the airway tunneling. So whenever we have a nodule which doesn't have an airway, you have peripheral TPD needles, you have Archimedes, you have mini BTPNA, several ways by which you can puncture, go out of the airway, reach the nodule and take a biopsy. So thank you so much. So this is in fact a new era in diagnostics. I'm very sure all of us will adapt these technologies in the near future and which will help us perform biopsies more safely and more accurately. Thank you so much.
I would like to thank my friend, Professor Najar Juna, for his elegant presentation about the peripheral longitudinal axis.